Hi, my name is Pamela Kunz, and I am a medical oncologist at Yale Cancer Center. It is my pleasure to talk to you today about what matters about clinical trials. These are my disclosures, and I will be reviewing clinical trial facts, clinical trial interpretation, what's on the horizon for new clinical trials, how you can find a clinical trial, and to bring in the theme, what matters most to make your next best decision as it relates to clinical trials. So first, why are clinical trials important? Clinical trials are key research tools for advancing medical knowledge and patient care, and we do clinical research to learn whether a new approach is safe and effective and which treatments or strategies work best for certain cancers or groups. And I think really one of the most important is that clinical trials provide hope. Yet only 7% of US adults with cancer participate in clinical trials. So I'd like to try first to separate myths from facts, and I think we will talk more about this as we go through the presentation. So the first myth is that clinical trial participants are, quote, guinea pigs. The fact is that strict guidelines are in place to inform clinical trial volunteers and protect their safety. We have informed consent forms and really go over the entire design of a trial with patients and families. The second myth, if I join a clinical trial, I will receive a sugar pill or placebo instead of the real medication. Placebos are used less and less in NET clinical trials and are really only ethical if there are no standard treatments available. And that has really fallen out of favor for NET clinical trials, in large part because we've had so many advances in the last decade. The third myth, once I decide to participate in a clinical trial, I cannot change my mind. When in fact, the truth is that you are free to leave a clinical trial at any time, even after you have signed the informed consent. Fourth myth, there are no costs associated with a clinical trial. While many aspects of a trial are covered, some participants will have copays with standard items, such as a standard routine doctor visit or a routine scan that might otherwise be done as part of standard of care. The fifth myth is that clinical trials are only for patients without other options. The truth is that there are clinical trials available for all stages in many situations. For example, that includes patients who've had curative intent surgery and may be looking at a clinical trial for postoperative treatment. So the path to drug approval in the oncology world is long. It includes preclinical studies in test tubes and in mice, moving on to phase 1 clinical trials with the purpose to evaluate safety, phase 2 clinical trials with the purpose to start evaluating efficacy. A phase 3 trial includes many more patients. In NET trials, it's often just hundreds of patients looking to identify whether a new treatment is better than an old treatment, and then moving on to FDA review. And even phase 4 trials is post-FDA review to learn more about safety. Sponsors for clinical trials include investigator-initiated, industry-initiated, and the National Clinical Trial Network, or the federally funded trials. So a sponsor is really who is responsible for the trial. Sometimes this includes funding, but really who is legally responsible. So investigator-initiated trials are usually an idea initiated by an academic physician, often smaller, usually available at a single institution, and the funding usually comes from that institution, sometimes philanthropy, a private organization, and or a pharmaceutical company. Industry initiated, usually that idea is from that pharmaceutical company, could be any phase, usually involves multiple sites and academic institutions, and sometimes is international, and that funding comes from the company. For the NCTN or federally funded trials, the idea is usually initiated by an academic physician, multiple phases, open at centers who participate in that National Clinical Trial Network, and the funding is federal. I'd like to move on and talk about why these federally funded NCTN trials are important. They represent an important way to ask practical questions that won't often be asked by pharmaceutical companies, like standard of care comparisons. In fact, we have a number of these trials in the NET space because we need multiple sites in order to accrue effectively. So I've listed 5 here. Unfortunately, the first one, the Alliance trial of lutetium dotatate versus CAPTEM in pancreatic NETs, closed in March of 2025 due to low accrual. We still have 4 NCTN trials open in LungNet, PNET, GEPNET, and in pheoparaganglioma, but we risk of these other important trials closing if they don't accrue. I'm sure many of you are asking this, and I get asked this question: why should someone consider a trial for an already FDA-approved treatment? Well, a trial may be comparing one FDA-approved treatment to another, and we learn key information on how to sequence these treatments. There's usually equipoise for the treatment arms, meaning that we don't really know if one is better than another. And there are really no more placebo-controlled trials in NETs. So for example, that one that just closed was lutetium dotatate versus CAPTEM in pancreatic NETs. We don't know if one is better than another, and that question will never get answered because unfortunately that trial closed. The side effects for these are well understood because they're already FDA approved, and you will pay it forward and help future patients. So moving on to thinking about how we design and interpret trials, we think about eligibility criteria. It's like a checklist: which primary site, which grade, which stage, is someone progressing or not, have they had prior treatment? And then we think about how are we going to measure success of the trial. Usually the most common endpoint in NET trials is something called progression-free survival, or PFS. How long does it take for the tumor to grow? Overall survival, response rate, and safety are usually secondary endpoints. So I'd like to walk you through how we look and think about these metrics of success. This is a survival curve. This is often what's published when a clinical trial is completed. This is an example of a progression-free survival curve, and I'm going to walk you through the components. So that x-axis along the bottom is months. The y-axis is the progression-free survival probability, and the dashed line is the median progression-free survival. So we look at something called a hazard ratio. It's a hazard of progression. So a p-value is also reported that indicates the level of statistical significance, and a low hazard ratio and a low p-value are good for both. And we really want to see separation of those curves. So that yellow curve is the CAPTEM arm, and the blue curve is the temozolomide arm. This is an example from the ECOG 2211 trial. And that yellow curve being on top indicates that it did better compared to those two arms. It had a longer median progression-free survival of almost 2 years. We also look at shrinkage rates, and we measure that through criteria called RECIST, the Response Evaluation Criteria in Solid Tumors. Key features of RECIST, I get actually asked about this by patients. They ask on trials, can you measure every lesion? The answer is no. We pick 5 representative lesions, up to 2 per organ, and we then take those measurements and we do the sum of the longest diameters. I'm going to walk you through that with an example. So this is a picture of a liver, or pretend that it's a picture of a liver. And in yellow are an example of 2 liver metastases. One of them is 6.5 centimeters and the other is 2.5 centimeters. So the sum of their longest diameters is 9. Imagine then a patient has had 3 months of treatment. We then do those measurements again. Fortunately, this patient is having tumor shrinkage. Lesion 1 is now 2 centimeters. Lesion 2 is 5.5 centimeters. That sum has decreased, and there's a 17% shrinkage from baseline. They go on to get an additional 3 months of treatment. We've had further shrinkage. They've had 44% response rate. And then I'll remind you how we look at this. So we then, a complete response, partial response, stable disease, and progressive disease are the categories that we look at. And so for this ECOG 2211 trial, we saw that the total response rate, which is complete response plus partial response, was 34% in the temozolomide arm and 40% in the combination arm. And that combination arm did better, both in terms of progression-free survival and a little bit better in terms of that response rate. Another really important way that we measure the success of a trial are the side effects. And I would argue that this is one of the most important things to patients. So we actually grade side effects on a scale of severity, and we call side effects adverse events. The severity scale is on 1 through 5. And it's very specific depending on what that side effect is, whether or not it's related to the treatment or not. And then I will mention that patient-reported outcomes are becoming increasingly used in trials. These are often done through apps or online tools for patients to report their own outcomes. This below here is just an example of a chart of how we grade anemia through this criteria called the NCI Common Terminology Criteria for Adverse Events. So as we think about exciting trials on the horizon, I know that you've already had a presentation by Dr. Chan, so I'm not going to go into the details, but I wanted to have this for future use and future reference for you. But we have a number of trials in NET and paraganglioma pheo, pancreatic NET, CAP10 versus observation after surgery for certain patients who are at higher risk. The Sorrento trial, looking at octreotide every 2 weeks versus investigator choice, and another NCTN trial looking at temozolomide versus TEM plus olaparib in paraganglioma pheo. We have a trial in neuroendocrine carcinomas. These are the higher grade studies looking at immunotherapy. And then we also have a number of PRRT trials, and I know that you've had presentations by doctors Carreras and Chauhan. And I think this is an area where we are seeing many trials, both in terms of using lutetium dotatate, using alpha therapy like actinium-225. So that's the Action 1 trial. We're looking at PRRT retreatment. So really an exciting space that we're seeing new treatments. And then I'll end with a trial that we are looking at symptom management. So this is an oral somatostatin analog, so like an oral octreotide called paltusotine. And this is for patients with flushing predominant carcinoid syndrome. And we hope that this will open in the summer of 25. So how can you learn about trials? I think number one, your oncologist or NET specialist should really be your primary guide. This is a complicated space, and you should ask them first. Secondly, your regional cancer centers have websites that list often the trials offered at that site. I've listed a few institutions here who have been good partners with NCF over the course of the last year for patient events, but you can look up your favorite institution, and I'm sure that they have a website for clinical trials. Clinicaltrials.gov is a website sponsored by the federal government. It is, I will say, is often complicated to navigate. They have tried to make it a little bit more patient-friendly, so I encourage you to play around with it. There are buttons that you can click on, search terms, etc. That's another option. And then there are a number of patient support groups and professional societies that also have websites, including NCF, NANETS, and NetRF. So I think in terms of take-home points, I hope that you've learned over the course of the day, not just from my talk, but there have been incredible advances in the last 10 years in terms of treatment and imaging, really in large part due to clinical trials. They are critical to this progress and are reason for great hope in this space. I think what we're seeing are that there are a number of novel radioligand therapies, that's the PRRT, immunotherapies, and personalized therapies that are being incorporated into current and future clinical trials. And I think to bring it back to our theme, what matters most to make your next best decision? I think I would encourage everyone at times that a new treatment is needed, I would encourage you to ask your physician, what about a clinical trial? What clinical trials are available and what standard of care options are available? And I'd like to give a shout out to all clinical trial participants. Thank you so much. It's really been a pleasure to talk today.